Our next speaker is Dr. Ralph Rogers. Dr. Rogers is an assistant professor of medicine and clinician educator in infectious diseases at the Warren Alpert Medical School at Brown University. As an infectious disease specialist, he is intimately familiar with multiple infectious disease processes, and in his own institution, essentially to respond to supply chain shortages. He's been intimately involved with the implementation of multiple diagnostic tests to address the clinical diagnostic needs at his own institution. So Dr. Rogers, thank you for being with us today, and I'm going to turn the podium over to you.
Thank you very much for that kind introduction. I'm going to pull up my slides for you here. All right, hopefully everybody can see that. We'll take a little different of an approach here today and talk more about less the test itself, but how we're using it kind of on the front lines clinically and some challenges that we face with it. So primarily, we're going to be talking about molecular assays in this presentation, since we just had a wonderful presentation of the serologic assays. We'll go through basically some challenges we see. We'll talk a bit about the diagnostic or clinical sensitivity of these assays, which we're just starting to learn more about, and then talk a bit about how these assays are used beyond case finding. This will be a little bit more of a case-based presentation. Hopefully in the afternoon folks are still awake, so keep you with me. We'll start off with a case kind of stereotypically of what we see here in the hospital. So 72-year-old guy, fever, trouble breathing, was feeling well 4 days ago, golf, no issues, and then slowly has been getting worse, feeling a little bit sicker, prompting him to come on in. He's got several comorbidities, and this case is happening at a time where there's ongoing widespread transmission of COVID in our community. This is how he looks. He's got a little bit of a fever, he's breathing fast, lung exam is abnormal. And he's got some markers that perhaps he does have COVID. His white count's up, his lymphocyte count's down, D-dimer's up, and kind of testing for other common respiratory pathogens is negative. Here's his representative slice of his CAT scan on the right. You can see this kind of diffuse infiltrative process throughout, which is typical of a lot of these patients. But his PCR is negative. So kind of set up the straw man argument here. So, does he have COVID? So arguments saying yes would be, well, he's got a consistent clinical syndrome, a lot of transmission in the area, high pretest probability. We don't really have a clear alternate diagnosis, so absolutely, yeah. Whereas you could also argue, well, he certainly has some respiratory infection, but his diagnostic test is negative. He has had illness for several days, so it should be positive. So he doesn't. Maybe we should keep looking. Clearly, the easiest answer would be to say maybe he does, or perhaps he does, or probably, but that's not really definitive. So what I wanted to highlight really is the problems with maybe. So the impact an answer of maybe has on these patients. So as an individual, at an individual level, several challenges. So the clinical team taking care of these patients, this gentleman presumably may have COVID. All signs are pointing towards yes. And so if we disbelieve the negative test and say, oh, he's definitely got COVID, then we may very well be missing some other diagnosis that he does in fact have, whereas the diagnostic could have been right. Similarly, even if he does have COVID, there's a lot of things that we can't do without a positive test. So a lot of the directed therapies, which may or may not work, like remdesivir, convalescent plasma, etc., these, we're starting to see some signals that they may. Most of those we're unable to give unless there's a confirmed diagnosis, either through EUA or through a clinical trial, etc. All of those need a confirmed diagnosis. Similarly, beyond directed therapy, there's a lot of other adjunctive therapies that I'm sure each hospital has their own, but things we're finding may be helpful to these patients that we certainly wouldn't want to do unless we knew absolutely that they had COVID. Anticoagulating people with just basic D-dimers, things like that. And kind of more globally, it's difficult to have conversations with patients, with families, if we don't really know what they have. We're learning more about this disease course and how it affects different people with different comorbidities. It's an entirely different conversation if you are sure this is what's going on versus I'm still not sure. It's sometimes challenging on a personal sense to have those conversations in that way. Zooming out a bit and talking about the institution, there's huge policies that are affected by a maybe test. If somebody is coming in and they have a negative test, where do you put them if you think that they still have the infection even though the test is negative? There's in many places still limitations for personal protective equipment. So if they're negative, do you take them off precautions? Probably not. If you have a high suspicion, certainly that's easy to say yes or no in a specific case like this one. But how do you make an institutional policy? Anybody who's had a test, you keep them on protection unless they've had 2-3 tests until they get better. It's a tough policy-making decision to make, whereas a clear yes or no would make that policy easier. Similarly, patient flow, sometimes that delays how they get out of the emergency room. Patient and staff cohorting. A lot of hospitals with a overwhelming number of folks are making warm units where everybody on the unit has this infection. Do you put these maybe people with the folks who definitely have the infection, or do you put the maybe people with folks who don't? Similarly, issues with visitors come in, and then when folks are getting better and we're getting ready to discharge them to home or to a nursing facility, we really need to know whether they definitely had the disease or not when we talk about precautions, quarantines, things like that. To zoom out one more level beyond just the hospital setting, in the community, it's, do you start the ball rolling for contact tracing if it's just a maybe case, if you have contact tracing available. Similarly, all of the data that we're getting with these tests are feeding into our larger public health decision making. So it's unclear the impact that these maybes are going to have. As an additional case, this is kind of more on the outpatient side rather than inpatient. We see a lot of these folks as well. A 67-year-old with fever, just one day of fever, but otherwise is feeling pretty well. So normally, who knows what she's got. The issue is, she's pretty immunocompromised. Kidney transplant 2 years ago, multiple immunosuppressive medications, multiple comorbidities, and this is at a time when COVID is running rampant in our community. Similarly, she has a negative test. What do we do? Does she have COVID? You could argue, well, we're not quite sure what she has, but there's a high pretest probability since high prevalence in the area. Don't really have another clear answer, so sure, she's got it. I think no is a tough one too. It could be anything. She had negative testing, no respiratory symptoms. She definitely doesn't have COVID. Hard to really say that. And again, in this case, the answer is probably maybe. Maybe she does, maybe she doesn't. We don't really know. A lot of the issues for ambulatory patients are the same as for inpatients. There's a few different ones. So as an individual outside the hospital, should we tell them, cancel other plans, stay in the house, don't talk to your family, don't go anywhere, presume that you have it even though your test is negative? It's kind of a hard sell. Similarly, should they be interacting with other people? Should we, and the bigger one from my end is, should these high-risk patients who may progress to more severe disease rapidly, should we be bringing them in, either to the hospital or to the emergency room if we're worried that because of their immunocompromise, they may progress rapidly even with a negative initial test? The other two are kind of similar to prior. So what I've expressed thus far is kind of some angst at diagnostic uncertainty. This diagnostic uncertainty is something we all deal with all the time in the clinical world. And again, it's not unique to COVID. There's many other disease processes or infections where, even though we may believe we have a clear black or white test that tells us yes or no, the answer is in fact much more nuanced. I think what's unique to COVID is for a lot of these other processes or diseases or infections, we have a lot more insight into the diagnostic performance of the assays. So we have all this information on how well CT pulmonary angiography works for PE, whereas for COVID, these are all new and developing, so we don't really have that information. Similarly, these are pretty impactful diagnoses, as I mentioned, not just for the patient, but for a lot of the other things that surround them. Generally, when we have something that's that impactful, like cancer, we really want a piece of biopsy. We want something that's a definite yes or no for something that's impactful. And right now, we don't necessarily have that for COVID. I think a lot of you are very clearly familiar with all the different characteristics that go along with molecular assays. I'm going to concentrate a bit on the determinants of diagnostic performance, so the pre-analytic things. So things like where you're getting the sample from, how you're collecting it, and basically how sick you are. Are you just had symptoms for a day? Have you had symptoms for 10 days? You just have a little fever and sore throat? Or are you in the ICU on a ventilator? The way we use these for case finding kind of depends primarily on the pretest probability. A little chart there on the right to show you the typical if you have a low pretest probability, you're going to need a pretty high performing test to move you towards a high probability afterwards, and converse as well. So for somebody with high pretest probability, like our first patient, the negative test is really not that reassuring. But that leads to the next question. Well, in the clinical sense, what do we do next? How do we proceed from there? Similarly, for a medium pretest probability, kind of like our second patient, again, a negative test still isn't entirely reassuring, especially if we're really worried about them. If they're a high-risk patient and may progress rapidly. Similarly, it's great to have all this information, but what do we do next? How do we treat them clinically next? We're stuck in the maybe category. And then finally, I won't talk too much about, but if we're using a molecular test to screen asymptomatic individuals, there we have a very low pretest probability, presuming you have a low local prevalence. And so a negative assay might be more reassuring, although it really, again, depends on the population you're testing. We may very well miss some pre-symptomatic or entirely clinically asymptomatic cases, although unclear what impact that might have. I want to talk briefly about diagnostic sensitivity. That's kind of what we've been getting to along with here. So what can we do to explore that? One of the first kind of understandings we had of that was from the experience in Wuhan, where it first came out. So this is a study that came out I think in March, describing the experience in January and February in Wuhan. And basically their patient population was everybody with a CAT scan and PCR within 7 days of each other, for a total population of 1,000. 600 of those folks had positive PCRs, and the CT chest was mostly in agreement. So that's kind of one thing that came along with it, is that CTs are often abnormal in folks with clinical disease. What was more interesting is their efforts to explore the diagnostic or clinical sensitivity of this molecular testing. So 300 folks had an initial negative PCR, but a positive CT chest. And then when they use it as the gold standard, a positive CT chest and a chart review or clinical correlation determined who the true positives were. At least 150 of those were highly likely, and another 100 or a third or so were probable. If you include both of those categories, then you'd be suggesting a diagnostic sensitivity of about 71%. And these are all sick, hospitalized folks. Clearly, this is not a perfect analysis. The CT findings could have been due to some other viral illness. The clinical correlation similarly could have been due to some other viral illness. So it's really unclear if this is a true measure of the diagnostic sensitivity or not. They did another analysis where they looked at eventual positive PCR as the gold standard. This is a bit smaller of a group, and to jump to the conclusion at the end there, it suggests a negative predictive value of around 77%, which, as we'll see, is in line with a more recent larger study as well. This analysis is clearly limited by small numbers. So this was our first kind of reported in the literature sense of, despite the high analytic sensitivity, maybe we were dealing with a test and a disease process and testing procedures that weren't necessarily perfect. And so that when this came out and amongst our ID colleagues and my pathology colleagues, it's caused some consternation. First, again, to concentrate on how this affects the whole system. So, if you suddenly are telling folks that, well, I know I told you the sensitivity of the test was super high, we're going to catch everybody with disease, but, now maybe we're having some indication that's not so high, that can give some real mixed messages. So, somebody who comes in the hospital, that first patient had a negative test, certainly policies change throughout, but perhaps they're off precautions, and then a few days later, they're calling the ID consult and coming back, maybe you should retest that patient just to double check the PCR. The team turns around, looks at you, and the patient hasn't been on precautions for a few days. Can really, really add to some challenges. We are faced with what else we can recommend. PCR is negative, but you have a high suspicion. What else do you do? These are all kind of back of the cuff things to do. Hey, think about repeating the test. Think about trying a different test if you have a few available. Think about trying a different area to test the same thing site. As mentioned in the last presentation, a lot of these folks are either coming in later in their course, or this disease process is often biphasic in a lot of folks. So maybe have initial infectious symptoms, maybe simmer for a few days, and then really get bad. So we actually are seeing a lot of people without a diagnosis that are quite some time into their illness. Perhaps there is a small role, even though it's not designed that way, for adjunctive serologic testing. And then the default is always, put our heads together and come up with a clinical diagnosis, but that can be unsatisfying for a number of reasons that we went over already. So after we're kind of struggling with that unknown diagnostic sensitivity for some time, and then just recently, I'm happy this came out before I finished my slides, we were able to see another center's experience. So this just came out in JCM, I guess a week or two ago. This is the experience in New York City, New York Presbyterian. High number of samples, high number of patients. And for some background, these are mostly inpatient, mostly symptomatic folks. So these are the folks we're seeing in the hospital. Of those, around 3,000 folks had repeat testing performed. And if we call this our subpopulation, prevalence there was about 43%. And the interesting group is those who had an initial negative result. They defined in this study a true positive as somebody who had an eventual positive PCR. And you can see of the initial negatives, about 19% had a subsequent positive result, similarly giving us a negative predictive value of around 80%, which again is in the setting of a prevalence of 40% or so. It's difficult to translate that back to an overall diagnostic sensitivity, and they kind of bookended it as if everybody did as bad as this subpopulation, your sensitivity would be down near 60%, whereas if these were the only false negatives, then you'd be all the way up to 95%. So certainly somewhere between those bounds makes sense. What number it is, we don't know for sure. Beyond providing some more data on what the diagnostic sensitivity is, they also gave some suggestions about clinically what to do for the next step. They had some kind of data-driven suggestions. So their thought was, in that first patient where you have a high pretest probability but a negative initial test, think about resampling the same day just to make sure you're getting the swab all the way to the back of the nose in case the first one was not so deep. And then another retest maybe 2 days or so later. On the off chance that they just had a barely not detectable viral load and they're still on their way up. 2 days later, you might be able to presume that that was the only limiting factor, but that would soon be improved with a subsequent testing. There, as you can see with the graph on the right, there's a continual drop in those who remain negative. So there is still going to be some false negatives after this first time, I think due to testing factors as well as really disease factors. What else? And then the other kind of thing we haven't really talked about, less case finding, but more folks who you already know have the disease, but need a negative test for whatever next step they're going on to. So if they're being discharged home, if they're being discharged from a nursing home, if they need clearance before a procedure or an operation, there's a lot of infection control policies that suggest you need a negative PCR prior to doing that. Different institutions are going to have different policies. At ours, sometimes we're testing folks every 2 or 3 or 4 days because we really want that negative, and we're kind of finding that's an exercise in futility, and this study supports that suggests that a repeat test is likely to continue to be positive until at least 2 or 3 weeks after that first positive. So it kind of gives some data-driven guidelines to making policies about how we might take that next step. And again, beyond case finding, I'll give you one more case here, something to discuss. What we're running into now is folks who have previously been positive, and then what to do with them when they come back to us a few weeks later. So this is a bit of a complicated case, but I'll walk through it. 45-year-old guy comes in with persistent trouble breathing. Got a history of HIV/AIDS, low CD4, although he's on therapy and he's got well-controlled viral load. 7 weeks ago, he came here with pneumonia. PCR positive for COVID. We gave him a 10-day course for remdesivir, got a little bit better. He had a negative DFA for pneumocystis, but a positive beta-D-glucan. Again, he had stopped his bacterial prophylaxis several months ago. So we said, well, maybe he's got pneumocystis as well, treated him empirically for that. And then in addition to that, he's also got a concern for underlying lung disease. He has had actually months, although he hasn't been hypoxic before, he's had months of dyspnea, and his CT chest actually had some concerning findings where perhaps he had some underlying ILD in addition. So ID was consulted, pulmonary was consulted, all the subspecialists are called in, and the consensus is, all right, let's get him through these acute infections, step back, reevaluate. So send him home on a little bit of oxygen after he's feeling better. And now he's coming back 7 weeks later, 2 months later, saying, why am I not better? Again, his symptoms are similar. He's completely out of breath, just walking from bed to the bathroom, still needing some oxygen to survive, but no other new acute illnesses that we can pick up just by clinical history or exam. He's got no new fever, he's got a little bit of cough, but nothing new. So we test his PCR, and it's still positive. This is 7 weeks later. Other diagnoses kind of unrevealing. His repeat CAT scan of his chest again shows some things going on in the lower lobes, which might be that ILD, but in addition to that, he's still got these patchy GGOs or kind of infiltrates throughout some other parts of his lung. So again, to set up an unanswerable question, which is often what we do, what's causing his dyspnea and hypoxia? Is it the COVID? Either, is he just somebody who's been persistently symptomatic throughout these nearly 2-month course? Is he someone who, got better from COVID and then got sick again? Clearly, I don't know that that's necessarily been described yet. The same questions we could ask about the pneumocystis. Is that really what's going on here? Is this all just a fibrotic or inflammatory process? Is there some other infection we're missing? And again, the answer is always clearly going to be maybe it's any of these, but the diagnostic, which kind of could really steer towards or away from A, is challenging. We know from clinical experience from multiple publications that this PCR molecular test is going to be positive for a long time. Again, that's not unique to COVID. I think what's unique to COVID is how often we check it. Most other diseases, you check it once, you got it, and then you eventually get better. It's a new disease. There's lots of infection control issues, and we are checking this test very frequently in very many people. And again, there's been publications on kind of each of these steps, but what's the relevance of a positive assay versus, how far they up on the threshold versus quantity of RNA versus intact virions versus culturable virus, whereas what we really care about is transmissible virus or clinically important virus. And I think we have all these other surrogate markers, but that's really what we're looking for there at the end. And again, we use repeat molecular testing for many categories of folks where it's not too impactful if it's still positive, because there's a good reason for it to be positive, for discharge, transfer planning, pre-op, pre-admit, etc. But what's really a challenge for us is folks like I previously described, which are not, he's not the one case that we've seen. We've seen multiple cases where weeks, or that he was outstanding because he's months later coming back in. They have some respiratory illness, and they have a positive viral test. Is that is it really the COVID causing the infection, or is it something else going on? It's something we still need to find some answers for. It kind of sums it up there. We still don't know what to make of it in certain scenarios. Take-home points briefly. I think it's important to kind of step back and think beyond the individual patient, which I know lots of folks do as a clinician. Sometimes we get caught on the individual patient, but the diagnostic performance of the assay impacts a whole ton of things, from the individual all the way up to the community. We really need some more information on the clinical end of things about the diagnostic clinical sensitivity of these assays so that we can help sort out what's going on. There really needs to be less on a global, all tests coming in, but more on specific populations. So how does this test perform in asymptomatic individuals? How does this test perform if we're doing seroprevalence studies with low prevalence? And that's about it. So I'll turn it back over to you, Paul. Thanks.
Well, Dr. Rogers, thank you so much for providing us today with what I would call a really nice perspective about how, as an individual physician treating these patients, how you're kind of integrating the use of these different tests. We only have time for one question, and the question I'm going to ask you, which we may not have a lot of information yet on, the reason I'm asking it is because it's a topic area that we haven't otherwise addressed during this meeting. Is there is the potential in the future for testing that's based on viral antigen as opposed to molecular or antibody. And based on your experience as a clinician in viral antigen testing for other infectious diseases, can you see a role in the future for viral antigen testing to complement the other approaches, especially to help you address some of these more complicated clinical presentations?
It's an excellent question. I think, for the case finding, I think we probably want, from a clinical sense, the most sensitive test we could get, which presumably would be molecular rather than antigen testing. That being said, I completely agree with your, I think, implied point, which is that in some of these later cases, we might be oversensitive, right? So a molecular test might be picking up cases that aren't clinically relevant. A persistent positive molecular signal may, in fact, not be clinically relevant at all. You can think about the almost less a respiratory infection, but more almost like a C. diff test, where the PCR we know is going to be positive, but what does that mean? So I 100% agree. I think that there will be some role for antigen testing in that scenario, not case finding, but clinical relevance of presence of RNA. Absolutely.
Great, thank you so much. I think I want to turn the podium, again, thank you, Dr. Rogers, for your excellent presentation and being with us today. I'm going to turn the podium back over to Dr. Emily Lee.